Greetings. This is Dr. Jim Drzegescu, your CHC Medical Director. We are pleased to provide and continue to grow our CHC Educational Library, which was created to educate CHC members about initiatives and best practices for improving the consistency in delivery of care following clinical practice guidelines. These topics were selected based on their overall value for improving our patients' health. Clinical integration relies on our collaboration with each other in order to have the greatest impact for our patients that we collectively serve. We hope you find the presentations in this educational library useful. We value your membership and expertise. If you have any suggestions for topics to add to this library, please let us know. I hope you enjoy the following presentation.
Lauren Mansell. I'm a physical therapist specialized in pelvic oncology and lymphedema physical therapy at Palos Health, and I am here to discuss pelvic rehabilitation with you. So what is pelvic rehabilitation? We're going to go over what the pelvis is, what kind of function the pelvis provides, and how to send patients to pelvic rehabilitation. Pelvic dysfunction is incredibly costly. The annual estimated cost is roughly $412 million. We know that conservative treatment, such as pelvic rehabilitation, can reduce those numbers. Additionally, it's really important that we look for treating chronic pelvic pain with physical therapy. Rates are incredibly high in women and can be, anywhere from 15 to 25% depending on the study, or as high as roughly 80% of women with interstitial cystitis having chronic pelvic pain from that myofascial dysfunction. So we can really manage these chronic conditions with conservative means of physical therapy in order to reduce this utilization and achieve shared savings. Pelvic rehabilitation addresses the ability to either achieve independence or become independent with activities of daily living. We look to treat any bowel dysfunction, bladder dysfunction, and sexual dysfunction. For pain, there's many different types of pain diagnoses that come into physical therapy, which may include vulvodynia, coccydynia, endometriosis, interstitial cystitis, irritable bowel, prostatitis, prostodynia, any unresolved back pain, unresolved hip pain, postpartum pain, post-surgical pain, fibromyalgia, and of course that chronic pelvic pain that can come in for physical therapy. For incontinence, we can treat stress urinary incontinence of urine, urgency frequency urinary incontinence, and then the mixed urinary incontinence of both stress and the urgency frequency. Additionally, we treat fecal incontinence and anal incontinence. Constipation is another issue that is addressed. Or if there's difficulty with having bowel movements and straining, we can treat those incoordinated muscle activity patterns. Pelvic dysfunction is incredibly prevalent. Within women, one study found that 67.5% of women disclosed multiple types. Actually, most women actually had multiple types of pelvic floor dysfunction. For anal incontinence, there was a rate of 20%, urinary incontinence at 50%, over 50%, constipation at 33.2%, and obstructed defecation at 26.8%. It is really important to also note that this study did not take into consideration pain disorders. It looked strictly at bowel and bladder dysfunction. So if we're not asking these questions, we really need to be mindful and ask questions of our patients. Additionally, pelvic dysfunction is not it's not solely an issue of age or aging. Women between the age of 20 to 39 had a roughly 10% rate of pelvic dysfunction. From ages 40 to 59, it was 27%. Aged 60 to 79, roughly 37%. And then women 80 and older had a roughly 50% rate of pelvic dysfunction. And again, this was urinary and bowel only. We were not looking, these two studies were not looking at pain. We can treat any age of person. I have treated up to a 96-year-old woman and a 98-year-old man as of this time who were willing and ready to do the full availability of pelvic rehab. Pelvic dysfunction is also prevalent within men. I treat a lot of men in my practice, and I see a very large amount of post-prostatectomy, urinary incontinence, and additionally, depending on whether the neurovascular bundles have been spared or not, I will also see and treat erectile dysfunction. In general, about 75% of men will have incontinence a year after surgery, and with 50% suffering 2 years after. When we utilize pelvic rehab from a surveillance model, so actually having them come in, getting a baseline measure, providing information and education on how to properly utilize their muscles pre and post surgery, we have much improved rates. Our rates are approximately 86 to 90% dry by a year. So sending patients to physical therapy, prostate cancer treatment is really important. Additionally, there is non-bacterial prostatitis. So this is one of the labels for chronic pelvic pain in men. Can be very taxing for both patients and providers, where patients are coming in with what looks to be a UTI, but then their urine drop comes back negative. So we know that this is actually a high-tone, non-relaxing pelvic floor that we'll go into later in this presentation. But just know that non-bacterial prostatitis, or CPPS type 3, can affect approximately 10 to 15% of men. And physical therapy works incredibly well with reducing that pain. So what is the pelvic floor? What is the pelvis? So the pelvis is this area under our abdomen, above our legs, the huge bowl-based, the two nominants with the sacrum and back. And your pelvis does everything. So as a physical therapist, I am very highly trained in connective tissue and connective tissue dysfunction, including muscular dysfunction. So these two drawings just really show there's two main layers of pelvic floor muscles. There's actually 3 layers, but the intermediate is very small and has a few muscles. But these 2 main layers have the urogenital triangle. So if you can, right here on the female, urogenital triangle on the male, with the levators that are underneath. So the levators go away under keeping those organs in. The pelvis is incredibly important from a functional standpoint. It provides support of the organs. It provides sphincteric support of bowel and bladder. The pelvis and pelvic floor allows us to engage in sexual activity and also to bear children. The pelvic floor provides stability of movement, of being able to use our arms and sitting and walking stairs. Any action that you do involves the pelvic floor. And lastly, the pelvic floor provides our sun pump, which is lymphatics. So helps us in keeping our bodies healthy. Here's a picture of pelvic floor musculature of a woman. Again, we have the 2 main layers, urogenital triangle, which connects here, sternal sphincter to the coccyx, with the levators underneath. And there's that intermediate, that level 2. And then the second picture just shows looking down from the pelvis, just how the whole base is structurally, it's all muscle. Additionally, within male, urogenital triangle, followed by the levators underneath. In physical therapy school, I did not know I was going to be a pelvic specialist, but I do remember when we were in gross anatomy, when we were dissecting out the pelvic floor, I remember just how small this urogenital triangle was, both in men and women, and just how large the levators were. And I've been able to use that memory and even with functional assessments. And if I can get the levators working well, our patients do so well. The pelvic floor musculature has to be able to contract. It may actually lift. Sometimes it doesn't. It has to be able to relax and then bulge. So most patients and physicians think that pelvic floor is all about Kegling, and we'll get into that in a moment. It is not. The ability to contract does nothing if we're already in a contracted or shortened position. So really just telling a patient just to do pelvic floor contractions or to Kegel, Kugel, I've heard all different ways of saying the man's name, but telling them to do the contractions may or may not be the best way to address, because they may not be doing their contractions correctly. Also important that we look at pelvic stabilizers. So knowing that when the muscles aren't contracting and relaxing properly, the other pelvic stabilizers become compromised and dysfunctional. We see that pain and coordination, reduced proprioception, and then the bowel and bladder dysfunctions. We have multiple pelvic stabilizers that we will look at your patients when you send them into us, including abdominals. And just know that when you send your patients in for pelvic floor physical therapy, that we're going to look at all connective tissue from the base of the neck to the knees. It's really, we are assessing and possibly treating all of those areas. When you are sending to physical therapy or pelvic rehab, finding a therapist that is strong in manual therapy that will correct the dysfunction, reduce pain, will increase that proprioception, improve coordination, and then restore that bowel, bladder, and sexual function. That's the whole goal. Some of the tools in our toolkit include behavioral modification, done via extensive education, relaxation techniques. We show patients their pelvic floor, we show them anatomy and physiology in our anatomy texts before even doing any of the assessment or evaluation. We'll prescribe therapeutic exercises, manual therapy, both for patients to be doing at home and for us to do in the clinic, a home management program, because the goal is to get patients independent as quickly as possible. We can also use biofeedback, which is a pretty generic term that is, it's an external source of teaching to the patient. So at Palos, we have the ability to do sensor-related biofeedback. We have real-time ultrasound, so we can look at what the muscles are doing in real time. We can also utilize the patient's hands and feeling their muscles contracting and relaxing, and or the patient's the physical therapist's hands also to see and give feedback. It's very common that most patients will use either their glutes or their abdominals to perform a pelvic floor contraction. So we'll use biofeedback of just the hands over the abdominals or the hands on the glutes to make sure that they're nice and soft while patients are doing their pelvic floor contraction, if and when we're ready to get patients to that level of doing that exercise. We also can prescribe, look at core strengthening, and we really, we are looking from, the neck down to the knees. So we want to make sure that everything is operating optimally and functionally, and we're not forgetting anyone. We can prescribe stretching programs, give vast amounts of education. We're looking at posture, body mechanics, other repetitive strains that may be coming from their work or lifestyle. Additionally, we may recommend some durable medical equipment based on what they need. And of course, we want to correct any fascial restriction that is maybe part of the patterning that's no longer helping that patient be healthy and happy. Pelvic rehab is not Kegling. I cannot stress this enough. Just doing Kegels is not a pelvic program, and if a patient is just doing that, I would want to reassess that program. We want to look at the ability to be coordinated. Are they using the right muscles at the right time? Are they aware of what muscles to use, what they're not using? What's their proprioception like? Do they have range of motion? Do they have the ability to relax the muscles, to contract? Do they have good strength from that tension length curve model? Are they strong because they're tight, or are they strong because they can relax and contract? And of course, looking for any kind of restrictions and tonal issues. Most Kegels are actually done wrong. So this picture is showing a Valsalva movement. When I see this in post-prostatectomy patients, this is the number one reason that I have men before their prostate surgery. They come in to show me what kind of exercises they're doing, and about at least 3/4 of them are doing a Valsalva. I think they learn that pattern from heavy lifting, from maybe different kind of exercise routines, but it's a bad pattern because it will cause increased leakage after having a prostatectomy. So is the patient holding their breath? Are they Valsalvaing? Are they pushing instead of pulling in? And additionally, maybe are they even using their pelvic floor muscles? Are they using their abdominals? Are they using their glutes? I've seen patients using their eyes to do a pelvic floor contraction where they're really gripping their face. I've seen toe curlers. So we really want to make sure that the pelvic floor is identified and they're contracting the right muscles and then relaxing them the whole way. So here is Arnold Kegel. Really, cool little side note. He was a physician here in Chicago, and he was a surgeon. He lost his ability. His fine motor started to decrease, so he no longer did surgeries here in Chicago. He moved out to the West Coast and became an OB-GYN and started catching babies, and noticed that after having babies, women had increased rates of urinary incontinence, and that if he strengthened their muscles, and he was very big on contract and relax, so he had the right idea. That's just his name and his, what he brought forth, that really created this squeeze mentality. And I've seen some really heinous information and education on how to perform a Kegel. So that is one thing we really have to correct and make sure it's done right. Poor man. One day I'm going to find his family and write a book on this, because I find it totally fascinating that he is the elusive Kegel. But thank you, Dr. Kegel. That length tension curve is much more important than that quote-unquote strength, that ability to clench. You can have a clenched fist and just clench it more, but that's not very functional. You need to be able to relax and lengthen your entire hand to then do a nice, strong contraction. So again, that's an analogy that I'll use with patients when talking about their pelvic floor. That length, that awareness, that coordination, that ability to isolate the correct musculature is way more important than Kegeling or just, doing these strong contraction that may or may not be the correct muscles. And again, this is only one part. Like, that's only the strength component. We need to make sure there's no tone issues and no myofascial restrictions either. So tone, incredibly important. We know that if you have a normal muscular tone, you just have that appropriate tension. So on the last slide, it's right there, that C area on the slide, that sweet spot, the middle area. Whereas when you have high tone, you're going to be over on so this is a high tone pelvic floor. So this is less length, high tension. Additionally, if you have low tone, you don't have enough tension. That increased length. So as you can tell, this high tone, the high tone is incredible. And we'll test out everyone and see where they're at. We can see some low tone after birth injuries, with some people just seem to have lower tone in their musculature. So we will test all of them. Mayo Clinic had a fantastic article that they offer 1 CME for. It's titled Recognition and Management of Non-Relaxing Pelvic Floor Dysfunction. And they are talking about a high tone pelvic floor. So that non-relaxing pelvic floor is really easy for us to treat with manual therapy. Again, it's that really clenched musculature that we will find all sorts of myofascial restrictions within. So in the article, it states, primary care providers should be able to identify women with this constellation of symptoms, perform a focused physical examination and selected tests to exclude other causes of chronic pain, and provide early referral to a physical therapist skilled in the treatment of pelvic floor dysfunction. So some of the symptoms that we see with non-relaxing pelvic floor dysfunction are pain, urgency frequency of urinary incontinence, the urgency frequency urinary incontinence. We will find incomplete urination, incomplete defecation, constipation, pain, and another good one is nocturia, waking up in the middle of the night to urinate. These are all signs of non-relaxing pelvic floor dysfunctions and all things that we can easily treat within pelvic floor physical therapy. When you send patients to pelvic floor physical therapy, in general, our usual plan of care may be up to 1 time a week for about 12 weeks, and that's very generalized. If some patients only need 4 or 5 visits, some patients need more than 12 weeks. The reason we go with 12 weeks is there's some typically we see patterns that have occurred that are the source. There's muscular patterns that are affecting their function. So it takes us 12 weeks to get them to retrain that habit or that muscular pattern. It also takes about that long to bring down some of the myofascial restrictions that we see in the pelvic floor musculature. Know that when you refer to Palos Health, that this is a manually based program. We are highly trained. We teach all over the country. We teach for Herman and Wallace Pelvic Institute, which is a manual based educational institute. Know that we have the highest level of expertise. We are highly rated, that academic centers will refer to us, knowing that we have this strong program. We have real-time ultrasound. We have really great tools to work with to help your patients kind of get better. Know that we are very upfront and we tell them, listen, we cannot touch you without your consent. My joke is always like, I can't touch you without your consent because that would be called assault. Like everything is patient supported, patient driven. I can give them all the information of how I can help treat their symptoms. But again, it is very patient driven. So even though we're a very high level, we have a high level of technique that we can use here, we only use what the patient is comfortable with. Again, you will receive an assessment from us, and our goal is to provide that treatment to get them better. There are pelvic rehabilitation specialists have a post-licensure specialization or certification. There's two that you may see. One is called the WCS, that is through APTA, that is the Women's Health Certified Specialist. And then there's a PRPC, which is a Pelvic Rehabilitation Professional Certificate. That's through Hermia Wallace. Additionally, the website, pelvicrehab.com, can also help you find pelvic specialists in your area by zip code or name. If there are any questions or concerns, please feel free to reach out to me. Again, my name is Lauren Mansell. I am a pelvic oncology lymphedema therapist out of Palos Health. I am mainly out of the Orland Park Health and Fitness Center location. It's just south of the Palos South complex. I also am at the hospital for tumor board and for training, and I'm at the hospital frequently for my team, so feel free to reach out to me. We have amazing therapists here at Palos Health. Feel free to reach out to any therapist that may be in your area that are doing this work. It takes very special people to do this work, so hopefully you connect to whoever is near you and you can have a great working relationship with helping our patients return to full function of their bowel, bladder, and sexual